Welcome to our webinar entitled NTRK Fusion Positive Non-Small Cell Lung Cancer, Perspectives from Pathology, Oncology, and Beyond. Today, I'm joined by three outstanding faculty. My name is Dr. Justin Gainor. I'm the director for the Center for Thoracic Cancers at the Massachusetts General Hospital and an associate professor of medicine at Harvard Medical School. I'm joined by Dr. Lynette Sholl, who's a pathologist at Brigham and Women's Hospital in Boston and professor of pathology at Harvard Medical School. We're also joined by Dr. Paz Ares, who's the chair of medical oncology and a practicing thoracic oncologist in Madrid. And we're also joined by Mr. Stevan Bradford, who's a patient who will share a unique perspective on NTRK fusion positive lung cancer. Here are our disclosures. This is a note to say that this program has been made possible thanks to an educational grant from Bayer. And this program is also eligible for CME credit. This is just a reminder that at the end of the webinar, you'll have the opportunity to fill out a questionnaire in order to claim your credit. In our learning objectives today, we'll be covering NTRK fusion positive lung cancer from pathology, oncology, safety, and patient perspectives. Here's our agenda for today. We'll be starting with a pathology case-based discussion. We'll then move on to a discussion of the management of NTRK fusion positive lung cancer, followed by discussions of safety and adding a unique patient's perspective. We'll wrap up the webinar with a panel discussion where there will be opportunities for question and answers. At this point, I'd like to introduce my colleague, Dr. Lynette Sholl, who will be sharing with us the pathology perspective. Lynette?
Thank you, Dr. Gainor, for the opportunity to speak today. My name is Lynette Sholl. I'm a pathologist at Brigham and Women's Hospital. I have the following disclosures. The case I'm presenting is of a 23-year-old man who presents to his primary care physician with complaints of back pain, night sweats, and a 10-pound weight loss over the last 1 to 2 months. He has a 1-pack-year smoking history. He undergoes a chest x-ray that shows a pleural effusion, followed by a CT scan, which is showed on the right, that demonstrates a moderate pleural effusion. Interestingly, no obvious lung masses, and best seen on PET scanning, diffuse osseous metastases. Based on this presentation, which of the following is the most appropriate next step from a pathology perspective to guide diagnosis and molecular testing? Is it bronchoscopic biopsy of the lung parenchyma, sputum cytology for malignant cells, bone biopsy of metastatic lesion, or pleural fluid cytology for malignant cells? So the correct answer is pleural fluid cytology for malignant cells. In the absence of a lung mass and in the presence of a pleural effusion, pleural fluid cytology with cell block preparation is minimally invasive and allows for both cytologic diagnosis and for molecular testing, including, if needed, NTRK fusion analysis. A bone biopsy could be considered if the pleural fluid is non-diagnostic, but this will be more invasive and is complicated by the requirement for decalcification of bony specimens in order to permit for histologic processing, and this step can interfere with molecular testing. Sputum cytology and bronchoscopic biopsy are less likely to yield diagnostic tissue in the context of the absence of a clear lung mass. So here's an image of the pleural effusion cytology. As you can see, this is a very densely cellular cytology specimen containing innumerable atypical cells, present as single cells and as small clusters. Immunohistochemistry was carried out on this specimen, showing that the tumor cells were positive for TTF1 and cytokeratin 7 and negative for P40, CK20, and chromogranin. These findings are consistent with a diagnosis of metastatic lung adenocarcinoma. Rapid targeted molecular profiling performed initially demonstrated that the tumor cells were negative for mutations in EGFR and BRAF. as well as for fusions in ALK and ROS1, and PD-L1 immunohistochemistry was negative. Subsequent comprehensive DNA-based next-generation sequencing was performed and showed the presence of a rearrangement involving NTRK intron 1 with an intergenic region on chromosome 4. The identification of the partner gene that was fused to NTRK1 was unclear, and ultimately from this information, it was difficult to determine with certainty whether there was indeed a functional rearrangement involving NTRK. No other mutations of biological or clinical significance were identified. The TMB was modestly elevated, and as you can see from the copy number profile at the bottom, there was a significant degree of chromosomal instability, as well as notably a deep deletion in the CDKN2A gene. So let's talk a little bit more about testing for NTRK fusions. The testing approaches that are accepted for detection of NTRK rearrangements from clinical trials that ultimately led to drug approvals include DNA and RNA-based NGS, fluorescence in situ hybridization, as well as reverse transcriptase PCR. Of note, for FISH in particular, in certain tumor types such as infantile fibrosarcoma, where the partner gene is consistently ETV6, FISH for that particular gene is acceptable as a surrogate for NTRK3 gene rearrangement detection. Just to comment further on NGS-based NTRK detection, when testing the DNA, the challenge is that most NTRK rearrangements occur based on breakpoints that occur within the introns. The introns in NTRK, where these breakpoints occur, in particular in NTRK2 and 3, are very large, greater than 100 kilobases, and these contain highly repetitive regions that are difficult to target using hybrid capture methodologies. This leads to limited utility of DNA-based methods, particularly for detection of fusions in NTRKs 2 and 3. The common breakpoints are highlighted by the blue arrows in the image to the left. In contrast, RNA-based strategies that target transcripts will detect only those expressed transcripts. And this particular assay can be designed with a very focused analysis of those exons where the expressed transcripts are likely to occur. Both hybrid capture or amplicon-based sequencing strategies can be used from RNA. In particular, anchored multiplex PCR is a widely used strategy, and this has been shown to have improved sensitivity over DNA-based testing. Multiple studies have demonstrated the superior sensitivity of an RNA-based strategy. Here is one study from the Memorial Sloan Kettering group that examines the sensitivity of their DNA-based impact panel relative to a combined approach examining both the DNA and the RNA. And as you can see from the table, the sensitivity is only about 80% for detection of fusions in NTRKs based on a DNA-only strategy, with a general inability to detect fusions within NTRK2. And interestingly, for fusions in NTRK3, most of those were detected based on targeting of the partner gene ETB6. So in general, DNA and RNA-based approaches appear to be the most robust and sensitive for NTRK fusion detection. And a question a lab might ask is, do we need to perform comprehensive DNA and RNA sequencing in all of our non-small cell lung cancer cases? The benefit of this dual strategy is that it permits for a priori confirmation of both functional rearrangements and identification of non-functional rearrangements that can be detected in the DNA. This is, however, a more costly strategy, as it's essentially going to double the cost of sequencing. And it also requires that a laboratory develop a total nucleic acid extraction strategy or another paired DNA and RNA extraction workflow. Other labs will implement a sequential strategy where you perform DNA NGS followed by RNA testing, particularly when the DNA NGS is negative. And you can argue that in most cases, particularly for lung cancer, which are driven by point mutations, and in some cases copy number changes, RNA testing up front for fusion detection may not be necessary. However, this ultimately delays identification of fusion drivers that are going to be missed using DNA-based approaches. Single gene and small panel strategies are still feasible in some settings. Fluorescence in situ hybridization, it does require a cytogenetic lab setup. In addition, multiple probes are required to cover all of the fusions involving the NTRK 1, 2, and 3 genes. And it's important to remember that with FISH, the presence of a rearrangement does not necessarily indicate an oncogenic event because of the fact that FISH can agnostically detect structural rearrangements. There's not an inherent functionality to any alteration that is seen by FISH. So molecular confirmation may be needed in some cases. And in general, this is a relatively expensive approach to screening. RT-PCR is a fast and inexpensive strategy. Its sensitivity, however, is limited by the scope of the assay when targeting defined gene partners. It does require a multiplex design, and there are a large number of 5' fusion partners that can be bound to NTRK. Finally, pan-Trk IHC is something that's readily used in a pathology practice. There's a number of clones that have been published, and some image examples from known positive cases are shown here in this slide. However, the performance of pan-Trk IHC relative to DNA RNA sequencing is inferior, both in terms of specificity and sensitivity. So any result from pan-Trk IHC should be confirmed using a reliable molecular method. In particular, we recognize that some well-defined sarcomas with alternative genomic alterations can have pan-Trk overexpression. Just to circle back to our case, our patient underwent targeted RNA-based fusion testing that confirmed the presence of a TPM3 NTRK fusion. He was started on entrectinib with progression after 10 months, then transitioned to larotrectinib with progression after 4 months, and then finally transitioned to chemo and immunotherapy. The patient survived 3 years from the time of his diagnosis. Just to wrap up, there are multiple strategies in existence for detection of NTRK fusions. DNA-based testing is challenged by large introns and the technical difficulty of NTRK rearrangement detection. Pan-Trk IHC should always be interpreted with caution and confirmed, and comprehensive DNA and RNA strategies are preferred for NTRK fusion detection. And with that, I am pleased to pass the stage along to my colleague, Dr. Paz Ares, who will now be presenting on the management of patients with NTRK-positive non-small cell lung carcinoma. Thank you very much.
Thank you, Lynette. So I'm Paz Ares. I'm a medical oncologist at the 12th of October University Hospital, and I will be leading today with the treatment of NTRK-driven disease. And I mentioned at some point a clinical case as I should. Those are my disclosures. And as I mentioned, I will actually lead today with oncogenic mutations on the NTRK genes. This is very important because today we know that non-small cell lung cancer is more than a single disease. Actually, oncogenic signals are detectable in more than 60% of the cases. The more frequent ones are being those involved in the KRAS genes, and more than 10 targetable, actionable gene alterations are happening in non-small cell lung cancer. One of the less infrequent ones are those involved with the NTRK genes. Those are detected in less than 0.5% of the cases and can affect NTRK 1, 2, and 3. NTRK 2 being the less frequently involved one. This is a relevant family of proteins TRK encoded by the NTRK genes that are very important in the differentiation and maturation of the central and peripheral nervous system through signaling to the PI3K, AKT, and MAP kinase cascades. We have detected fusions with more than 80 other genes, partnership those fusions, and being more frequent on NTRK 1 and 3, and that is in a number of solid tumors, including, as I mentioned, in non-small cell lung cancer. You see here NTRK gene being located on chromosomal 1, NTRK 2 in chromosomal 9, NTRK 3 on chromosome 15. You see the list of parameters that are affecting non-small cell lung cancer, more frequently in NTRK1, less frequent in NTRK2, and intermediate NTRK3. More often that happen in never smoker or light smoker, but could be in a smoker, more frequently in adherers, but some patients also having squamous cell carcinoma histology. I'm just going to start with this clinical case. As I told you, it's a 65 years old man that was actually coming from China to Spain some years ago. Before that, this smoker with a history of diabetes, type 2 diabetes, had been diagnosed in China of an squamous cell carcinoma of the right lung, right upper lobe, stage 3B, and treated with chemoradiation in China. The patient came to skip pain, and some 6-7 months after finishing the chemoradiation, had a relapse on a right supraclavicular node, but also in the mediastinum. And that was actually confirmed with fine needle aspiration of the supraclavicular node. With relapsing disease, the patient was started on pembrolizumab. Remember, at this stage, PD-L1 expression was about 30%. And the patient was actually not improving the way he was feeling. He didn't notice a clear improvement on the size of the subclavicular node, and some coughing was increasing. The patient was presented in our hospital for a second opinion with a suspicion of progressive disease. The CT scan was reviewed in our hospital. We suspected likely pneumonitis, and actually he asked for a new biopsy of the supraclavicular node and an NGS, not only in the supraclavicular node tumor, but also in the liquid biopsy. And as you see here, the CT scan was clear, showing a clear node on the supraclavicular node. The biopsy showed a squamous cell carcinoma, TTF1 negative, P40 positive, and the NGS didn't show any actionable genomic aberration, only a P60 mutation. But the liquid biopsy showed an NTRK fusion that was clearly detected, and important to say, ctDNA fraction was quite high, good quality, 40% in this liquid biopsy. Then I went back and actually was able to confirm that in the sample from the biopsy we sent for NGS, there was a cellularity of about 15%. I have to say that this patient, before we started any treatment, we confirmed by FISH the patient had a mutation also in the solid tumor biopsy. My question here would be, well, it looks like this patient is having an NTRK fusion. What would be your appropriate management, treatment management for this patient? Would be A, radiotherapy to the supraclavicular node, B, add-on chemotherapy to the immunotherapy treatment the patient is on, 3, start a currently approved TRK inhibitor, or you would prefer palliative care only. Indeed, here, my solution would have been treat the patient with an appropriate and approved TRK inhibitor. Of course, you could consider a treatment within a trial with another TRK inhibitor. And I think those data would be supported by the NCCN and ESMO guidelines, among others. You see here what happened after 2 months of treatment with entrectinib, which is the one of the approved drugs in our country, but the only one reimbursed. You see here a clear improvement of the lymph node on the left is much higher, 3.5 centimeters to less than 2 centimeters here on the right. picture of the CT scan done in October. If we go to the next slide, I like to show here those agents that are available for a number of years now, larotrectinib and entrectinib, both approved in my country. You see, larotrectinib is a really specific inhibitor of the NTRK genes, and as you see here in this Gainor inhibition panel, entrectinib is also a very good TRK inhibitor, but you see that is also affecting some other kinases at the same concentrations as well. You see, these agents have shown clear activity in preclinical models, but also we have robust data in the clinical scenario. The initial trial with the larotrectinib resulted in responses in about 2/3 of the patients with non-small with solid tumor, looking specifically on those patients with non-small cell lung cancer. Of course, you see responses again in about some, I would say, in green here, about again more than 60% of the cases. PFS was about 31 months, being 22 months for those patients with NTRK tumors. And I think that number is pretty important. Indeed, you go to the next panel, you see what happened with entrectinib. Again, very nice responses, more than 60% in the solid tumors, being about 62% in those 41 patients here included with non-small cell lung cancer. Duration of response was 27 months, I remember. The overall PFS was about 16 months. That may be a bit less across trial comparison as compared to larotrectinib. Going a bit more in detail on the larotrectinib trial, you see here that some 32 patients were included. Most of them had adenocarcinoma. Even, as I mentioned, some patients with squamous cell carcinoma may have these fusions. 40% of the patients had some brain metastases, and most of them were heavily pretreated, some of them with more than 2 or 3 prior lines. You see here that responses were seen in a good number of cases. In this particular study, 24 patients out of 32 had fusions affecting NTRK1, 9 patients NTRK3, and actually in one case, both fusions were specified. You see responses in some 2/3 of the cases, 66%, with slight variations, more frequent, with the better PS and with less prior lines, but specifically very consistent magnitude of responses across the different populations studied. Median duration of response was in the range of 3 years, 34 months. Median PFS nearly 2 years, 22 months, and median OS was 39 months, nearly 4 years. So I could say the data pretty impressive altogether. We have some data regarding mechanism of resistance in 18 patients. In most of the cases, we detected a non-target mutations, particularly on the solvent front region, that was affecting some more than 80% of the cases. In 2 cases, 11% had off-target mechanisms of resistance affected BRAF mutations or MET amplifications, I have to say. And you see here that some novel NTRK inhibitors are available with 9 responses, even in TKI pretreated patients, responses in some 45% of the cases treated with selitrectinib or repotrectinib. On those patients treated with repo with TKI naive disease, responses were a bit higher, nearly 60%, and the same proportion of patients responded of those with solver front mutations. Again, with ICP 7 to 3. Responses were seen in 2/3 of the cases, 66%. And importantly, at the ASCO, we have seen data with thoratrectinib in some 49 patients treated, heavily pretreated before being included in the trial, and responses were observed in 84% of the cases. And I think those data are also to be taken into account. So just let me finalize with some take-home message. I think NTRK fusion are rare in non-small cell lung cancer, but frequent, actionable, and actually the result with available agents are pretty good responses in more than 2/3 of the cases, typically long-lasting, including intracranial activity for most of the cases. The safety profile is relatively mild, I would say. Novel agents are now available with activity in TKI pretreated patients with different profile of activity, but also of safety. And I think those data will help us to choose among the agents that are coming for the near future. This is everything I have to say today, and I then hand the virtual podium to Dr. Gainor. Justin?
Thanks so much, Luis. So today I'll be discussing the safety of TRK inhibitors in NTRK fusion-positive lung cancer. Here are my disclosures. So this slide summarizes the currently FDA-approved TRK inhibitors. We have 3 different agents. And what I've done is I've listed the indication with respect to NTRK, as well as the selectivity profile in terms of the kinases that are inhibited by each agent. The reason I bring this up is because what we'll see is that the side effect profile of each agent is commonly dictated by the selectivity profile. So you'll see here, lirotrectinib hits both tracks A, B, and C, and entrectinib targets tracks A, B, C, as well as ROS1. And repotrectinib has a very similar profile in that it hits tracks A, B, C, and ROS1. Safety monitoring is essential to detect and manage class-specific toxicities associated with TRK inhibitors. And common gaps in AE management include under-recognition of low-grade but persistent adverse events and inconsistent monitoring protocols across treatment centers. So we'll go through each agent individually and highlight some of the core adverse events. We'll kick things off with lirotrectinib. These data were recently updated at the World Conference on Lung Cancer in 2025. What you'll see here is this is data from 2 different studies on the left with approximately 37 months of follow-up. Here we have a tornado plot showing the most common adverse events. And the way this is broken down is on the left side are all adverse events regardless of causality, and on the right are treatment-related adverse events. So we'll focus on the treatment-related AEs, and you'll see that some of the most common ones include myalgia, elevations in ALT and AST, constipation, dizziness, and weight increase. So approximately 25% of patients with weight increase. If you look at the top of the slide, you'll also see that dose modifications were common. So approximately 50% of patients had a dose modification for any AE. But the total number of patients who actually discontinued therapy due to AEs was actually quite low, only 3.1%. On this slide, we summarize the adverse events of entrectinib in non-small cell lung cancer. These data come from 3 different studies outlined on the left, and this is after a median follow-up of 26 months. On this slide, the AEs are divided based on grade 1, 2, or 3. We see that the most common adverse events are dysgeusia, elevations in creatinine, diarrhea, and transaminase elevations. Beyond these, we also see some TRK-mediated adverse events, so dizziness in approximately 25% of patients. Also, like larotrectinib, we also see weight gains in uh, approximately 30% of patients, as shown here, including 11% of patients who experience grade 3 weight gain. So we're seeing consistent themes in some of these adverse events, which come from track mediated adverse events that are off tumor effects. Rounding things out, this is data from repotrectinib. Here, the data is focused on both ROS1 and NTRK fusion positive patients. So it's a much larger data set, so 426 patients. These are data from the TRIDENT-1 study with a median follow-up of 22 months. You'll see that the data is depicted a little differently here. Rather than frequency, it's arranged by organ system. We see nervous system disorders on the upper left. Most common AEs there are dizziness in 65% of patients, followed by dysgeusia, peripheral neuropathy, and ataxia. Importantly, about a quarter of patients also had some reports of cognitive impairment. And in a few slides, we'll sort this out and how this may be a track-mediated adverse event. In terms of GI adverse events, constipation, nausea, and we see dyspnea in approximately 30% of patients. What about weight gain? We also see this with repotrectinib. So 16% of patients experience weight gain. The total number of grade 3 or higher, though, is lower at 3%. So this slide summarizes some of the core AEs that we just reviewed on the last 3 slides. I should add that this is mainly focused on this figure is mainly focused on larotrectinib and entrectinib. It doesn't include repotrectinib, but it calls out some of the most common side effects that clinicians need to be mindful of when they're using track inhibitors. So these include, again, things like ataxia, myalgia, nausea, peripheral neuropathy, and muscular weakness, all on the left side. And then on the right, we again see dizziness, dysgeusia, weight gain, and diarrhea. So I already alluded to this, but when we start thinking about some of these adverse events, we saw recurring themes, and that's because some of these are actually on target adverse events. So we know that tracks A, B, and C play a role in normal human biology. And so when they are blocked, particularly within the CNS, we see very characteristic adverse events. So, for example, track A inhibition, this can lead to sensory neuropathy, as well as issues with pain sensation, which we'll talk about in a few minutes. Track B inhibition can lead to hyperphagia, hence weight gain. It can also cause nociception issues and memory impairment, so perhaps leading to some of those cognitive issues that we talked about. And then finally, track C inhibition can also cause some issues around proprioception. So then if you look at the percentages of the AEs above, you can see, weight gain is quite common with the track inhibitors. Dizziness, withdrawal pain, and paresthesias, these are all on target AE. Now it's starting to get a little bit more granular. This is meant to show you, this is taken from a very nice paper in Annals of Oncology from Dr. Liu and colleagues, just showing the rates of weight gain over time and what this actually looks like in terms of time course. So I think this is helpful. The figure in the upper left, where we see that patients start experiencing the weight gain commonly within the first 3 months, and you see that it gradually increases over time, and this can even reach grade 3 status. And so we'll talk about some of the strategies of how we manage weight gain in a few minutes. Likewise, dizziness can occur fairly early on. If you look at the swimmer's plot here, the yellow boxes depict where patients first started experiencing dizziness. So you see that this is a very early AE. And I think it's important for clinicians, the description of dizziness, right? We all know that this can be a very challenging term to differentiate. What do people even really mean? Are they describing this as vertigo? Is it positional lightheadedness? Is it imbalance? All of these are described under the broader term of dizziness, but I think it's really important to try to really tease this apart, what patients are experiencing. And then a somewhat unique adverse event is this concept of withdrawal pain. So this is upon discontinuation or holding of a track inhibitor, patient can actually experience a flare in pain syndromes. And so here, if we look at this with this swimmer's plot, it's quite different, right, than the dizziness one, where dizziness is very, very early on. Here, this is actually more at the end because that's usually where you're holding therapy, right, or stopping therapy. In this slide, we provide an overview of some of the management approaches for some of the most common track-mediated adverse events. We'll start with weight gain. First, I think it's really important to counsel patients on uh, the expectation of potentially gaining weight on these therapies. So it really starts from a prevention standpoint that right away, emphasizing diet, exercise as part of starting a track inhibitor. One could also consider referring patients to a nutritionist um, in order to be more proactive. Among patients where you do see weight gain occurring, there are a number of different strategies. On the agent side of things, one can consider dose interruptions as well as dose modifications. And one can also think about the introduction of additional therapeutics. For example, in my own center, we will commonly refer patients to our weight center for consideration of a GLP-1 analog. In terms of the AEs of dizziness, both the vertigo-based or ataxia-based dizziness or orthostatic approaches, again, you want to counsel patients because these tend to be very early adverse events, and so expectation setting. For patients who are experiencing a lot of vertigo-based adverse events, tend to think about things like meclizine or scopolamine could be considered. I have a low threshold if this is very bothersome for patients to pursue dose modifications. And then finally, withdrawal pain. Typically occurs where you're either holding therapy or transitioning to another therapy because of disease progression. In these cases, one can pursue different strategies. There's treating the pain itself with NSAIDs, opioids, or even GABA analogs. But one could also approach this through reintroducing the track inhibitor or simply tapering it off to prevent the withdrawal pain in the first place. And I think that is a very reasonable strategy here. So we've now, this is just a summary. We now have 3 approved track inhibitors: larotrectinib, entrectinib, and repotrectinib. A subset of adverse events such as weight gain, dizziness, withdrawal pain, and paresthesias arise from on-target off-tumor effects. And so this really requires careful attention of the entire care team in order to ensure that patients are able to stay on therapy with the appropriate um, dose modifications and introduction of supportive medication. And with that, we see that rates of discontinuation remain relatively low, but it really requires careful monitoring of patients for both track-mediated and non-track-mediated AEs. We will now hear from Stevan Bradford on his experience as an NTRK fusion positive patient.
Hello, I'm Stevan Bradford. I'm living in Alabama in the Mobile area. I work in a steel mill, and I learned in January that I was diagnosed with stage 4 non-small lung cell cancer. In January, I was just visiting my primary care doctor for just a checkup and get my prescriptions recertified and reauthorized. And during that checkup, the doctor noticed a lump on my left side clavicle area, and that led to a chest x-ray and then led to a CT scan. So I wasn't feeling any type of pains, wasn't having any coughs, and it was just kind of a shock. And of course, here I am going to start researching what was being said, which led to some information that I was still waiting on a diagnosis, but now I've had some information that I've gathered, which was, kind of interesting but depressing. On my first meeting with my oncologist, he said, so they've done a tissue sample. So they have learned that you do have stage 4 endocarcinoma. And he was discussing with me that it's not curable, but it's treatable, and that we would be trying to send off some tissue and blood for some biomarker testing. Said it was important to try to find maybe a targetable treatment for me. Otherwise, I probably was looking at 2 to 3 years on the scheme of things. So we were pretty interested. And of course, I left there researching biomarkers and what they may lead to.
So Lynette, Louise, thanks again for joining me. It's always really powerful to hear a patient's in their own words, kind of what their experience has been. And so, wanted to spend a couple minutes just talking about the kind of on the provider side of how can we better support patients? Maybe I'll ask you, Lynette, on the pathology side of things, like kind of turnaround times, and how do you think about turnaround times as a pathologist? Because I'm sure every clinician is saying, I want this as fast as possible. And what are those rate limiting steps on the pathology side?
Yeah, sure. So, I think there's obviously two strategies. There's a tissue-based testing strategy, and then there's a liquid-based testing strategy. If we start with the tissue-based testing strategy, there's a number of checkpoints, right? So the biopsy has to be obtained. It has to be processed. You have to confirm you have adequate tissue and adequate tumor in that specimen. And then there's the process of actually receiving an order or triggering an order. And obviously the environment in which this happened varies tremendously from place to place. In some institutions, you may have reflexive orders that emanate out of pathology, and that can speed up the process of getting more information. In other settings, and a lot of this can be very much driven by the cost environment and what is considered to be acceptable practice for pathologists to test that pathologists are committed to order versus what needs to come from a treating clinician, et cetera. So a lot of variables there. But I think ideally you have a scenario where diagnosis is made, reflexive testing is initiated, and that's your mechanism to kind of get to an answer as quickly as possible with biomarker testing. For tissue in general, we're typically looking at somewhere in the order of 1 to 2 weeks for a comprehensive genomic profiling assay. It's probably closer to 2 weeks, especially if it needs to be sent out. There are other test types that are a little bit more focused, but can deliver some more focused information quite quickly, as in the order of a couple of days. I think we're increasingly moving to a place where there's a bit of a staged approach to biomarker testing, or you may have a very focused assay that can deliver results in, say, 1 or 2 days, followed by a reflex or kind of consistent usage of a more comprehensive panel to deliver more information that's going to give you a little bit more depth and hopefully cover any targets that are missed in that more focused assay. So on the tissue testing side, I think you're looking anywhere from a few days to a few weeks for an answer. And then on the liquid side, obviously that loops out the whole process of getting the biopsy and getting the path review and getting the order in for tissue testing. So we know we can cut down turnaround time to 7 days or less for liquid biopsy-based analysis. The challenge there is just sensitivity. And if you have a tumor that's not shedding as readily into the bloodstream, you may miss the key biomarker alterations from liquid testing alone. So we're often looking at an opportunity to pair the two of them to optimize the likelihood of finding a targetable biomarker.
Great. And I would say in my own practice, I typically will tell patients those timelines and usually try to touch base at least weekly, so that they're constantly seeing that we're thinking about them and they're not on an island. And so maybe we'll move on to our next clip and that'll be another springboard for discussion.
I was looking at starting chemo, and I actually did have one chemo treatment, not the full treatment, just one session. And then before my next, it was every 3 weeks. So at the end of that 3 weeks, before my next treatment was going to be, we found out that I did have this NTRK fusion, which we stopped the chemo and started looking forward to starting a targeted therapy. It was almost like me and my oncologist were learning this for the first time. He wasn't really up to date on my specific biomarker and what my therapy would be, and it was kind of like we're excited to start it, but we were also both looking for information. So I left out of the office, kind of wondering how this might go. So I started, of course, trying to research it for myself, how the different therapies would work for me, and was finding out that in some cases it was very, very good results.
So, Luis, how do you educate? Like, what are some of the challenges that you encounter in educating patients about these rare biomarkers like NTRK?
I mean, something very important is that they understand that we spend some time hoping to get the NGS results because we are able to identify a number of subtypes of lung cancer from which we not only have personalized treatment, but very precise treatments. And among those, there are some very exceptional cases, very rare cases, but it is very important to recognize them because we really have very good treatment for them. The outcome is somehow very differently, and particularly the treatment is very different as compared to the standard of care chemo-IO. If we like to really benefit those patients, we really need to understand that very well. Because of the type of treatment we are going to deliver here with a specific type of side effect profile, I think it's very important for them to understand. I tend to spend some time somehow anticipating the potential side effects, how to manage those side effects, including the fact that we may have to dose reviews at some point, which type of therapies may help. And in fact, at some point, we will have still more treatments down the road. And that is another important message here, that this is not going to finish with the first-line therapy. We have another type of opportunities down the road, and I think that's very important to educate on.
That's great. And Lynette, we see marked heterogeneity in reports, right? Molecular reports. Some are very prescriptive and even put therapies next to them. Others just report the alterations. For our community oncologists who are treating many, many different types of cancers, like, what are the challenges in educating our clinical partners about some of these rare biomarkers?
Yeah, the reporting is a really interesting challenge, I think, for laboratories and for consumption by the providers. You have to strike a balance between making sure that you're providing the critical information about what is a targetable biomarker, but not going overboard and positing that everything that you identify in a cancer is ultimately going to lead to a potential therapeutic option. So I think it's this very interesting kind of balance that you need to strike. We have tended to rely heavily on guidelines that point to specific genes as being associated with, say, in the United States, FDA-approved drugs, and making sure that those particular correlations between a gene, a known type of alteration in the gene, and the appropriate drug that those sort of pairings are brought up to the very top of the report. So you can quickly glance at it and say, okay, I have an EGFR mutation. I know there's an approval for EGFR mutated lung adenocarcinomas. We can move on. And then what do you do with the other 26 alterations that maybe you found? And maybe a few of those will point to an opportunity for a clinical trial at some point in the future. And maybe you can call that out, but you really have to figure out how to differentiate between those immediately actionable things and the things you might want to pull out of your back pocket when the time comes as you're thinking about additional clinical trial options. So I think that's really the task for laboratories to figure out how to strike that balance correctly. And then I think from the standpoint of providers and care institutions, putting forth forums in which people can have a conversation about the results on these reports, molecular tumor boards, really, I think, a critical a place where these types of conversations can be had. So really trying to resource institutions to provide that opportunity for their oncologists and other care providers, I think, is critical.
That's really, really helpful. And so now we're going to move back to hear from Stevan one more time, and that will give us an impetus to our last question discussion.
When I first started the targeted therapy, I was having some pretty good side effects in the beginning with muscle pains, and it seemed like each day it might be in a different area. And I was actually using compression socks and some massage machines it mainly was affecting me in the evening time. And that seemed to last about 2.5 weeks, and they kind of just went away. And then after that it happened, I did start having lightheadedness, dizzy spells, and also had a few occurrences of passing out, which led to me stopping my blood pressure medicines. So after that, I haven't passed out again, and I still get a little lightheaded, but it's manageable.
So I think Stevan's case really illustrates some of the issues that people can encounter, particularly early on with TRK inhibitors. So, Luis, how you already alluded to it in the last discussion, but perhaps you could expand. How do you prepare for patients for some of these side effects, and what's your typical frequency of follow-ups, especially at the beginning for your patients?
Okay, so during the time I'm waiting for the NGS result and maybe the initial interviews with the patient, I tend to somehow prepare for the general approach for targeted treatment. Then when I know that this patient is having specifically an NTRK-driven lung cancer, I'm going to go through the expected outcome, response, and so on. And I tend to, at the time I'm explaining about the side effects, I tend to emphasize that we are hoping or we're expecting the tumor to shrink at the same time, so that it's getting, for that very reason, I'm typically asking for a CT scan in 4 weeks. So, because this is when I'm expecting the initial, let's say, peak of side effects. And I really like to bring to my patient some good news about how the treatment is going. I typically see my patients like every second week for the initial 6 weeks. If my patient, I see something is wrong, I may give it a call on the week in the middle between every 15 days. And, I tend to anticipate mainly the more frequent side effects, as have been here reviewed. And, if things are not working, and particularly if dizziness is being strong and so on, I may consider to dose reduce if needed.
Yeah, my practice is very similar to yours, which is, I also see patients every 2 weeks at the beginning. I think virtual care has also made it easier for some of those, visits on the off weeks where you can just have a quick video and check in on things. And I also get an early scan. I usually go in that 6 week range, but you're right. It's really helpful to show people early on, and these drugs work really, really fast, right? Where we can typically expect to see a response at the time of that first scan. Great. So I do know we now want to move on, and we're going to take some questions. And then in the meantime, though, while we're waiting for some of the questions to come in, we wanted to call out some highlights at some of the recent congresses, specifically at ESMO 2025, recently in Berlin, where we saw some posters on NTRK and NTRK inhibitors. One that stands out to me. This poster at the top is real world outcomes. We know what the clinical trials, we just articulated what we saw in trials. I thought this was interesting in that TRK inhibitor use was still low in this real world population of NTRK solid tumors. Now, this wasn't just a lung cancer population, it was all solid tumors. And interestingly, most of the time these were being used in the later lines. Luis, does that surprise you that only 24% of patients getting a TRK inhibitor?
Unfortunately, I have to say that, for example, in Europe and maybe some other places worldwide is even worse. I mean, we have a big issue with NTRK drugs for a while. This has really been improving, but even, let's say, France, Italy, Spain, for a while, those drugs were only reimbursed for patients with, for pediatric patients, but not for adult patients. So I think that was part of the issue. Thank goodness this issue has been recently solved a couple of years ago. And that is the reason I think that number was really low. Of course, you go to South America, many places in Asia, thank goodness, this scenario is very different in the US. You're lucky about that, but that is a big issue. Having a good drug, a good therapy, and not being able to give it to patients, that is really, really tough.
Yeah, I think what you're hitting on is access. Access is critical, and I think you're hitting on important points, which is that even when people see the data, right, then being able to access the drug is the critical piece. Just rounding out some of the other abstracts here, we saw updated data. Another real world study looking at larotrectinib. Here seeing a impressive response rate of 61% in non-CNS tumors, dropping down in CNS tumors. Obviously, we know that while these drugs are CNS penetrant, the biology of those tumors are quite different. I think it's nice to see data that recapitulates what we're seeing in the clinical trials. Likewise, with our colleague Benjamin Bess presented a poster updating the repotrectinib data. And I would say, to me, what's striking in this update was the TKI pre-treated response rate with repotrectinib. So 50% of patients previously treated with the TKI is still having an objective response rate. So I think that's really encouraging, and I think it speaks to, Luis showed us some of the data on mechanisms of resistance, and highlighted some of the early data with repotrectinib, and I think this provides some additional data there. And then rounding out the list, we see the larotrectinib long-term responders, seeing a 5-year PFS rate of 68%. So a subset of these patients can have really durable responses, but we still need to push things forward and develop next generation inhibitors, because we know that acquired resistance continues to be an issue. So with that, please.
No, I think those data, particularly the long-term data, are really amazing, I would say. And, we typically have as a reference in the targeted therapy world, the data with LORLA in ALK-driven disease, like 60% PFS at 5 years. And the data here are even a bit better. So I think that is very important to keep this message to our patients. That is amazing.
I completely agree. And I think that's a perfect segue to our first question, because someone asked the question of how are TRK inhibitors going to change the prognosis of NTRK fusion positive lung cancer? And I think you just started talking about it. So maybe if you want to expand more.
Yeah, so I think, if you look at the very few patients that we now know in retrospect that they were NTRK positive but treated with chemo, that was a totally different history. So we know now those patients are really living for a very long time. Even, as you mentioned, we know even patients that had been progressing to first-line TKIs, they still have a very good chance of responding to next-generation drugs. More than half of the patients do respond, and survival is still quite reasonable. Going to nearly 2 years. So I think those data are really encouraging and have to be really transmitted to our patients.
I agree. And I think it also underscores the importance of making sure that we're managing the toxicities well, right? So if someone's going to be on a targeted therapy for 5 years, we really can't have them being dizzy every day, right? These are, things that for a day or so can be disruptive, but then if someone's living with that for years, it really is important for clinicians to ask about it, identify it, and then course correct, because these patients are living longer. Another question came up for you, Lynette. That is, given all the diverse fusion partners, what should clinicians look for in an NGS panel to check, if appropriate? And are all RNA sequencing approaches equal for NTRK detection? So I guess two questions there.
Yeah, they're very good questions. And I think, take those one at a time. The diversity of fusion partners probably has the biggest impact on a choice of a DNA sequencing panel. So as I discussed in my section, one of the challenges with NTRK fusion detection from DNA is the fact that the locations of the breakpoints in fusions occur in very large introns, generally speaking in NTRKs 2 and 3 in particular. And it makes it very hard to capture those breakpoints in a DNA-based assay. So you may be chasing them from the partner side. You may have better luck capturing that 5' partner than you do that kind of key kinase domain mechanism on the NTRK side. So you can hope that you build a panel that is able to capture that information off of that 5' partner, and maybe you just happen to sequence into that NTRK 3' component. So that's not the best strategy, honestly. So, alternatively, you just commit a lot of resources to covering those huge introns. That can drive up the test cost, and I think a lot of labs have tended to steer away from that, ultimately leading to a general recommendation that you would pair that DNA-based strategy with an RNA-based test, and that could certainly be a targeted fusion assay, a targeted RNA assay, where you're just looking for fusion transcripts from a given set of known oncogenic drivers. And I think those approaches work very well. The challenges can be if you have a degraded sample where the RNA is not good quality, you may not get a successful test. So there's always some challenges with handling RNA. One thing I would just like to point out is that as excited as I think we all are about things like whole exome sequencing is not going to get you your NTRK fusions, right? It's not a good strategy for detection of fusions. You have to then pair it with another RNA-based strategy, which could be, say, a transcriptome. So you could do RNA transcriptome. My experience is that RNA transcriptome is great for defining kind of a whole transcriptional profile, but sometimes it's not going to be quite sensitive enough to define these individual fusion alterations. So I think we're still getting there with the RNA sort of transcriptome technology for sensitivity of detection. For most places, I think a good quality comprehensive panel paired with a targeted RNA assay that's ensuring you've got coverage over your NTRK genes is probably the best strategy.
Yeah, as someone who's done lots of exome-based projects, it's always funny because commonly you then focus in on the 100 or 200 cancer-related genes, right? So even though you do the exome, you're then focusing on just cancer-related genes. And your point about that not getting you the fusions is a really important one. So, Luis, you showed some of the data on mechanisms of resistance. We have the on-target track mutation, solvent front, gatekeeper, but we also know resistance can emerge through off-target mechanisms. And so I think this individual is asking about how we should go about targeting off-target resistance and bringing up MAP kinase pathway if you were to see acquired KRAS, for example. How might you approach that here?
Yeah, always that is feasible to me. So if the mechanism of resistance is having a clear drug that is effective, such as the case today for G12C inhibitors, I tend to keep the NTRK inhibitor and add on the new inhibitor to the new target. In that case, G12C inhibitor. I mean, ideally, you like to have safety data for that combination, maybe the first time that is being done. So sometimes you cannot wait to have 30 patients treated and published, and then you have to decide. So I tend to comment my patients after discussing with the multidisciplinary team, and I just be careful the initial weeks and tend to be monitoring very carefully, including blood tests and so on. But, I had just very recently a case with MET amplification, and we are giving the NTRK inhibitor plus TEPO without major issues. So I think for most of the cases it's feasible.
Yeah, and we see, some of these bypass pathways, right, tend to be promiscuous. You mentioned MET, and that comes up over and over and over again, right? We see that in the EGFR resistance. We see that ALK. And we can see that here. We have time for one last question, and that is, this speaks to some of the efficacy data, but is how do you counsel patients in terms of like what they might expect in terms of the average time before they might expect to see resistance, and how do you treat oligo progression versus kind of more fulminant progression?
So the way I typically address this is, I'm having them like, I would say more than half of the patients could be okay in 5 years without progression. So that may happen earlier, but that gives them kind of a time. Second thing is, as you mentioned, if I'm seeing some oligoprogression or very slow progression, I tend to try always that is possible a local therapy and keeping on my NTRK inhibitor. Most of the cases that means stereotactic radiation, but in some cases it may include surgery, but more frequently stereotactic radiotherapy. But that, and sometimes you see patients that are having maybe some 2 extra years of disease control by doing so. So what are you using that approach as well, or?
Yeah, very, very similar. I think even though NTRK is rare, right? We take the same paradigm that we use for other targeted therapies, and I think extrapolate here. So our approach is very similar, and I also think that your willingness to continue beyond progression or SRS is also depends on the quality of your next line therapies and what other targeted therapies you have. So you might be a bit more willing to switch after if you have an excellent option. So that's why I think it is so important to have all these next generation TRK inhibitors. So with that, I just want to give a couple closing statements. I want to first thank you both. This has been a wonderful discussion. I've learned a lot. I wanted to thank Stevan for his perspectives. It is really, listening to patients is our North Star of oncology. So I really appreciate his time. Closing thoughts, NTRK fusions, as you've already heard, are rare, but they're clinically actionable and they can be transformative for patients. We absolutely need to test in order to find these alterations. You heard from Lynette. DNA, RNA, NGS provides the most reliable detection. You heard about some of the other kind of more limited assays. We heard about first generation TRK inhibitors delivering high response rates that can be quite durable. We also learned about mechanisms of resistance and next generation TRK inhibitors that are being developed to overcome that resistance, including trying to gain better CNS control. And I think we start with testing, and I think we end with testing too. It's really early testing and timely initiation of TRK targeted therapy is critical for our patients.